Well, good afternoon, everyone, and thank you for joining us for this webinar series with Epilepsy Foundation New England, brought to us by Aquestive. And we're really glad to be joined by Dr. Barry Gidal, who is the Professor of Pharmacy and Neurology at the University of Wisconsin-Madison. So, Dr. Gidal, thank you so much for joining us tonight, and I'll turn it over to you.
Great. Welcome, everybody. Thanks for taking time out of your afternoon or early evening. So let me just tell you what I'd like to do in our time together this evening. I wanted to, this is really an interesting and I think great time within our epilepsy management system, our milieu, if you will. You know, not only do we have a lot of new anti-seizure medications coming to market that, hopefully will provide greater levels of long-term chronic seizure control for our patients and with a lower burden of adverse effects. Well, along with that, over the last, couple of years, we've really made great strides in developing new acute treatments of rescue therapies. Because as we're going to talk about, this is something that, for reasons that I've never entirely understood, has been a little bit ignored in the epilepsy community. Maybe not so much in the pediatric epilepsy community, but in the world that I live in. And by the way, I should say my clinical practice is in the VA in Madison, Wisconsin, so an adult population. And certainly within the adult population, we don't really talk about rescue treatments nearly as often as we should. But again, now we have a lot of new options that are available that I do think represent an advance. So and by the way, I'd like to thank Aquestive for making this evening possible for us. So what I would like to do tonight, I want to talk about what are seizure clusters, and I'll talk a little bit about language, because sometimes the language and how we describe these events gets in the way of properly identifying which patients should receive some of these important therapies. So I want to talk about what that is. I want to talk about what some of the risk factors for these increased risk of these seizure clusters, and really what implications they may have for our patients. So why is it so, I think, incredibly important that we have good, effective therapy? I want to talk about seizure action plans. As this audience most likely knows, the Epilepsy Foundation, this was under the leadership of Patty Schaefer when she was at the foundation, but I certainly was part of that group as well, kind of redid our seizure action plans. And I think they're especially relevant and important in the era of COVID, and we'll talk about that. And then I want to talk very briefly about some of the medication options. Now, we're not going to be going into detail about the individual drug formulations, but I do want to talk about some general considerations and things we should be talking about with our patients, about what they should be thinking about. All right, so let's start from the beginning. What is a seizure cluster? Again, I'm going to talk about some language here in a second. But if we think about, our patients with epilepsy, one of the statistics that has really been very stubborn and has not moved in the 30 some odd years really that I've been involved in management of patients with epilepsy is about a third, maybe 40% of our patients are going to continue to have uncontrolled or very poorly controlled seizures despite treatment with one or more anti-seizure medications, anti-epileptic drugs. We had thought this number would change over time as newer drugs came to market. Most certainly it has helped a segment of our patient group, but the numbers still seem to be the same. Now, within that group, and we'll talk about, a little bit about, who's at risk for this disorder. It's been estimated, if you look at various studies that have been done, of looking at patients who are vulnerable to these seizure clusters. And again, I'll talk a little bit about what some of the different terms are in a second. It really kind of depends on what study, what population. Are they inpatient from video EEG monitoring units? Are they from reports from outpatients? Are they children? Are they adults? putting all that aside, study design aside, we're probably looking at somewhere around at least 40 some odd % of patients, at least. If you ask and if you look carefully, they have a pattern, an episodic pattern of seizures that come up that is sort of outside their normal pattern of seizure recurrence, and something that could be considered clusters. Now, there's a lot of interesting science that goes in behind this. Why do some patients with epilepsy develop these clusters and others don't? We really don't know quite what the answer. It could be that some patients may just have a lower susceptibility for seizure, lower threshold, if you will. It could be that some of these, and I'm sure I'm talking to an audience that probably has a lot of familiarity with this, that some patients may have a bout or a flurry of very small seizures that maybe are different from the big seizures that they have. And it's those little seizures that fail to sort of trigger the mechanisms within our brain to stop the seizure and stop it from going on. So it almost may be that they're self-propagating. And that when we get into this cycle of the little seizures, and this is an important educational piece, because I've had patients who have said, yeah, I maybe get the little ones, the little auras or the little feeling sensations, there may be a couple, 3 of them in a day, but they're not like my big one. But then you ask the question, well, can they ever lead to the bigger one? They go, yeah, come to think of it, they do. So again, there's a lot of things that we simply don't know why. But one of the things that we do know is that these events can lead to more serious consequences, including status epilepticus. Now, let me talk a little bit more about what is the definition. And I said, I wanted to talk a little bit about language. Last year, Epilepsy Foundation, right before the walk in Washington, about a little bit more than a year ago, sponsored a consensus conference. And one of the major issues was, how do we describe these? Because this is important. The reason that the language that we use is important for agencies like the FDA. How do they design a study? How do we diagnose somebody? How do we get the appropriate people in? I think it's important that for patients, and clinicians to be able to speak the same language, to be able to use language that we all understand what it means. And I think it's also important for the third-party payers, whether be that the government, be it insurance companies, understand what we're treating, and that maybe the language that patients and clinicians are using is maybe a little bit different from one of these terms, but what do we really mean? And how do we relate that to the use of the drug? So the other terms that are commonly used are acute repetitive seizures, serial seizures, flurries, bouts. But whatever language and words you put to it, the important thing, and this is the educational piece, I think, with patients and caregivers and clinicians for that matter, is really greater than 2 seizures within a 24-hour period of time. Now, I want to emphasize that, because again, these are we talk about closely grouped repetitive seizures. A number of years ago, people would say that, well, for a flurry or a bout or something acute repetitive seizures, it really needed to be a couple of seizures, maybe within an hour of each other. We know that recurring seizures within 5 minutes, we would call status epilepticus. So maybe not to really be considered a flurry or cluster, it had to be within a few minutes to an hour or 2. We now have expanded that. So if we have a patient, and this is what I do in my practice, if I have patients that will tell me that, there are just certain times, we'll talk about triggers, where they'll have like a bad day, where they know that they're going to have a couple spells, maybe one in the morning, maybe one later the afternoon or the evening, but they know that that may mean something really much worse the following day or the following night. So greater than equal to 2 seizures within a 24-hour period of time. Now, again, when we talk about these are seizures that tend to represent an increase in seizure spells over what the patient's usual baseline. And unlike status epilepticus, patients do tend, the hallmark of this is patients recover between seizures. So again, an important clinical point here, if we're talking about somebody having a cluster, we have a patient that will say, or the family member will say, yeah, they have a couple spells, but within those spells, they never really came back to normal. That is sounding more like something else that probably does need some medical evaluation. Okay, so typically recovery will occur between seizures. Now, we talked about what they are. We talked about some of the language. What are some of the things that can increase the risk? What are the likelihood? What are things can we do to talk with our patients about and for us to be aware of and ask the right questions? Well, one of the things that heightens my concern, my index of suspicion, if you will, are patients with really bad epilepsy and who have poor seizure control. And frequently the patients, the adult patients that I have that we have eventually called, acute repetitive seizures, or they have clustering. They tend to be the ones that we've not really ever been able to get more than a few weeks maybe of seizure freedom. So poor seizure control. Any patient who's still experiencing seizures should be discussing seizure action and rescue plans. And we'll talk about what those are in a few minutes. Symptomatic epilepsies, what do I mean by that? What I'm talking about, and same with post-traumatic epilepsies, are epilepsies where I know I've got a neurologic cause. I've got an autonomic cause. So say a brain injury, a stroke with a bleed, a brain tumor. In the pediatric world, say a cortical malformation, something where I can look and say, I have a known cause, versus one where I think perhaps there is a genetic predisposition or something that we still refer to as idiopathic, meaning we simply don't know. So this is important. So again, patients that I know have a known cause in my world, in my population, at the VA, those tend to be post-trauma and brain tumor and strokes are my main causes. So again, if I have a patient who fits that profile, has poor seizure control, I automatically start making sure I'm asking about any kind of patterning of clusters. EEG. Now, is the EEG diagnostic here? No, it's not. Sometimes if we find the EEG abnormality that's coming from outside the temporal lobe, maybe that tells us a patient may be at more risk. Is that something we would use to make a decision about a rescue plan? No, it isn't. Again, poorly controlled epilepsy, someone who's had epilepsy for a long time with really never achieving seizure freedom. And most certainly, any patient who's ever gone into convulsive or generalized tonic-clonic status epilepticus. These are patients who spend a lot of time being very concerned about, because if they've done it once, there's a great likelihood they will do this again. And these are patients we need to be building that rescue plan around. Now, I think for this audience, this is something that probably goes really without saying. Studies that have been done, Cheryl Hout and others, and Joseph Servin and a number of groups, Jim Wheelis, others have done these studies. Pat Benovich in Minnesota have looked at health-related quality of life, and asking simply the question is, do having seizure clusters, maybe they don't occur very often, but do they impact your quality of life? Absolutely. And frankly, they also, and something that maybe has not been studied as well, it impacts quality of life of the significant other or the family. As again, I'm going to guess this audience is familiar with, if a patient with poorly controlled epilepsy, and if they have these flurries or these bouts, and it raises the concern that maybe they're going to go on for something worse, maybe significant others or caregivers or parents stay home. Maybe there's all these other indirect costs that are associated with this. So we need to be thinking about it, and I try to think, that's why now it brings me to another educational point. Whenever possible, when I'm talking about rescue plans and seizure action plans, I need to be able to bring the significant other in, the spouse, or if there's an adult child that's helping to take care of one of my veterans or somebody, because no doubt they're involved in this whole process, and I need them to understand what the action plan is and whatever modality of rescue treatment that we're going to talk about, that they understand how to use it. It's more than just counseling the patient. Now, there's also some other interesting things that Dr. Penovich and colleagues came up with. It's that there's also this sometimes a disconnect, if you will, between patients and providers. There's a number of patients, I will say on the slide, a number of patients that will tell you that, or providers that will tell you, yes, I've talked to my patients about seizure clusters and what a cluster is and what to do about it. But when you talk with patients about that, and this studies have shown a disconnect, that maybe the majority of clinicians think that their patients understand this. It's only the minority of patients that actually really do understand or recall having this conversation. So what this tells me is I don't doubt that clinicians are educating patients as to what a seizure cluster is and how to recognize them and what to do about it and how to document them, and again, an action plan. But I think we all know that patients come into the doctor's office or the clinic, and there's a lot of information that's bombarded at them, that this is an educational point that needs to be brought up really, truly at every epilepsy visit. And we need to continually be bringing this up and refreshing it if necessary with our patients. So what do we do then? So how do we help bridge this disconnect between what clinicians think patients are getting and what patients think they're getting? On the clinician side, it's really incumbent upon us to get as clear a history as possible. Far too often, I hear residents and trainees simply ask the question, well, since your last clinic visit, have you had any seizures? Okay, usually, you get an answer, and you may get something like, yeah, I had a couple last month. We need to get more detailed history. And I also make a point of asking my patients, not only tell me about when those seizures occurred, was there more than one? Did they come close together? But also, well, did you have any smaller ones? Because sometimes patients will only identify, quote unquote, the big seizures. And they will frequently use the term aura and say, well, yeah, I did have some auras, but if I just sit down and I kind of get to a quiet place or maybe go to sleep, they tend to go away. They tend to pass and I don't go on. Well, that likely sounds like clusters to me. So again, we need as clinicians to be taking as clear a history as possible, but I also believe in advocating for patients. We need to educate our patients. You need to be providing this information to your clinician, and if they're not asking, you need to give them that information. Seizure diaries can be enormously helpful. We've put a link on here to epilepsy.com, which of course, as you know, is part of the Epilepsy Foundation, for seizure diaries. It's very easy to print these off. Patients can do this at home. There's all sorts now different smartphone devices that are becoming available that we can use, but this is the simplest thing where patients can print something off, write these down, and we educate them to look for a pattern. So if you tell me that you had a couple seizures last month, well, tell me, did they occur in the same day? And tell me what happened. And then I also look for what I call the triggers. If you tell me you had a couple seizures, had you had trouble sleeping the night before? Are you under a lot of stress? We now know that psychic stress, it really is a trigger for seizures. Alcohol, of course, this slide says alcohol binges. I would say, let's call it maybe excessive alcohol use, maybe not necessarily binging. Medication adherence, one of the biggest factors, and one that we can actually probably do the most about, are skipped or missing medications, either inadvertently from simply forgetting, or maybe the medication regimen, there's just too many doses per day. For whatever the reason, medication adherence is critically important. With women, there is so-called catamenial epilepsy, where looking at the rise and fall of estrogen and progestin can trigger seizures and clustering of seizures in some women. And then especially now that we're getting into the fall and influenza season, and it's obviously we're still in COVID season, but any kind of viral infections that cause fevers, illness, for some patients with fairly brittle control, this can trigger clustering. So again, from an advocacy point of view, every patient that we touch should have a seizure diary, or at least we tell them where to get one. And if they have a seizure, any seizure, even if it's not a cluster, try to give us as much information as possible. Now, I mentioned why is this important? Again, we talked about sort of the economic and quality of life issue. Clearly, any kind of seizure that a patient can have sets them up for injury. But we also know that clusters, we have very good evidence now and data that clusters can devolve into status epilepticus, which, as you know, can be a life-threatening disorder. And besides all the disruption, these clusters have another impact, is that they can land my patients into the emergency room or calling 911. This is in any time period. This is something we want to try to avoid, but especially in the era of COVID, where we're really doing everything we can to keep patients and their family members out of the emergency room. Is that, you know, recognizing these clusters and appropriate treatment, okay, is critically important. Now, this is, I've already referenced this. I got a little bit of ahead of myself. But again, looking at where this disconnect is for patients, you know, of what clinicians think in terms of rescue medicines or rescue plans, I should say, versus what patients think, and have they actually received something that they can use. So with that as a background, so we talked about the important, what's these terms mean, what are clusters, why they're important, because these flurries or bouts, or whatever term we use, of seizures can herald bigger things like status, but even if they don't, they can have huge impacts on not only the patient and the family unit, and on the healthcare system. If someone decides, if they have nothing available to them and they realize that something bad could happen here, of calling 911 and going to the emergency room, which now unfortunately carries its own set of risks associated with it. So what do we do? So let me now switch gears and let me talk about treatment. Again, this is really an exciting period of time. You know, our goal is to make sure we have a safe and effective therapy that's individualized for the patient and their caregiver. Again, because it's likely the caregiver that's going to be helping with this, that can be administered at whatever setting, home setting, school, work settings, what have you, with the goal of avoiding the emergency room and avoiding getting into the hospital. Now, up until recently, the last number of years, the main option that we had was Diastat, diazepam rectal gel. We'll talk a little bit about that. Recently, you know, well, let me, before that, one of the other things, which is not really a good strategy, and I just had a patient actually last Monday that this is what they did. Instead of, in the absence of having a good rescue plan, patients just took extra doses of their chronic medications. This tends not to work, and it may just lead to other side effects. That's not a good strategy, and it's surprising to me how many patients will do this in the absence of a good definitive therapy. So, rectal diazepam gel. More recently, we now have marketed FDA-approved intranasal products, both midazolam and diazepam. Before, these compounds were available through compounding pharmacies, but what we know is that the intranasal, the marketed formulations, are much more consistent and reliable. oral benzodiazepines. For example, Ativan, or maybe a small dose of diazepam, Valium. These can be very, very useful in some patients who maybe get the small warnings. They know something's going to happen, but they don't really have an alteration in consciousness, and they're able to manage their care. This can be useful. However, for a large number of my patients, that when they start having these flurries, there's an alteration in consciousness, they're really not going to be able to manage that of taking an oral medication. And then most recently, and what we will be soon having available to us, is diazepam buccal film, which I'll a little bit describe. It's basically a strip that you can put on the inside the cheek of your mouth that rapidly delivers this diazepam, this benzodiazepine medicine. And then the clinical trials are very, very promising, and hopefully we'll have that product fairly soon. So let me go through a little bit of detail about some of the different, more detail about the routes of administration. And here's where it's important, you know, when for clinicians to be able to understand, how do I compare these products? Now, if a patient were to come into the emergency room and in having acute seizures, most likely they would either get an IM or intramuscular injection, or more likely have an IV placed. Now, IV, once I place that IV, put that IV in, I can get a drug administered in a very rapid manner and get a very prompt action. The problem is, as you might imagine, that takes a medical professional to put in. Most likely in many places, EMTs will not be qualified to do it. It takes time, even in an emergency room setting. It takes a number of minutes to find an IV line, get it put in, drop the medicine, and administer it. So this has led to something, you know, confusion. I think when caregivers or clinicians read the literature and compare the onset of action, clearly, if I gave an IV medicine, once I give the drug, it's going to work the quickest. However, I need to recognize it's going to take me a while to get that medicine in. So IV administration really is not that practical outside of the emergency room setting. Intranasal is clearly a viable option. Rectal works. We'll talk about rectal, and again, then this buccal or in the cheek mode of delivery here. Now, what are the most important factors I need to consider when I'm thinking about what therapy I want to use? How quickly? It's very simple. How quickly can I get the medicine into a patient? Again, in my perfect world, every patient, the minute they had a seizure at home or any place else at work, would get an IV medicine. That's obviously, I don't live in a perfect world, none of us do. That's never going to happen. So I need to then look at how quickly and how easy is it going to be for a patient or a non-medical caregiver to administer one of these therapies. How many steps do they have to go through? And once they go through those steps, is that medicine going to get reliably absorbed? My patients also aren't always going to have their clustering of seizures right at home. They may be out somewhere. They may be in the mall. They may be in a restaurant. They may be who knows where. Whatever this mode of therapy, whatever this treatment, is it something that's easy to bring along with you for patients to carry? And I think that's sometimes an under-recognized logistical barrier. Can whatever treatment, can a patient bring it with them? If it's in a dropper bottle, for example, where they have to, a patient would, or a caregiver would have to draw something up into a syringe and then administer it through the nose, that's not very convenient. So again, ease of administration by anybody that can be easily trained. I need to have something that's, I want to be assured that's got a long shelf life, meaning doesn't have a quick expiration date. I need to have something that doesn't have to be stored in the refrigerator, that it can be stored, it can be carried with a patient in their pocket, in their purse, backpack, or wherever, but they can have it with them. But I want to have something that's available in dosing for all patients. Now, again, I take care of adult patients, but again, I need to have something that's got a broad range of dosing. And then finally, most importantly, I need to have something that's safe. And the main safety issue that I'm concerned with is I don't want to impair my patient's breathing and respiration, and I don't want to knock them out for hours and hours and hours. Okay, so those are my main safety considerations. Now, so we'll talk a little bit more detail in a second, but let's get back to, does this drug work? I've talked a lot of theory with you. I've talked about the need to stop these spells before they go on to something worse. Do I have any data to actually support this? Now, there's actually now a number of studies that are published. I'm just going to show you one tonight. This is a little bit of now an older study looking at it was a double-blind study. There was a diazepam, which is benzodiazepam auto-injector, and this was for patients who had flurries or had met their definition for clusters of seizures. So this was something administered by caregivers to patients. Again, because it needs to be something, whatever treatment strategy we're going to use, something that a caregiver can give. And let me try to orient you to this slide. On the vertical axis, maybe it's a little bit counterintuitive here, but the vertical axis is the probability of not having another seizure. And so you can see at the very beginning, patient had their clustering of seizures. They got administered the drug, either diazepam or a placebo. And as you go down over time, how long did it take until you likely had to give another dose or another seizure happen? So we start out at 100% and then we drop off over time. Now, what you can see here very clearly is that really, truly, the medicine began to separate from the placebo response within an hour. And very clearly, for when we think most of our patients are at risk for having a recurrent spell, very different. The probability of remaining seizure-free or cluster-free, however language we want to use, was significantly greater in those patients that were treated. Now, there are now a number of studies, particularly with diazepam, but also midazolam as well, that back this up and have been very, very consistent. So if you ask me the question, I give you all the theory and all the rationale, but do the medicines work if I can get them into my patient, even outside of the emergency room setting? The answer is absolutely yes. So how do we then go about individualizing? Well, the first step is we've got to have that action plan in place. And it needs to be something that the patients can carry with them. One of the things we've talked about is a group of us have trying to develop, besides the big action plan, which I'll show you, is in patients, I've encouraged patients to do this, take the relevant information and something that they can put maybe on the back of their smartphone or have something they can carry with them, because they may not always be carrying a big piece of paper, but the big piece of paper needs to be where family members can see it. Hopefully they feel comfortable enough in a work setting that their work colleagues can see it, or teachers can see this. So it needs to be accessible. And then we have to educate our patients that they need to activate that plan at the first sign of a cluster seizure. I've had patients who we've developed action plans for that when I asked why didn't they give a rescue medicine, and the answer was, well, I wanted to see if it was really going to get that bad. And then it did get that bad. So again, we need to tell patients and the family members, again, education, the first sign, use the treatment, do whatever what we're suggesting here if it's a drug treatment. Like I said, Up until a little while ago, all I really had was rectal diazepam. While I think rectal diazepam is a reasonable choice in some patients, maybe kids, maybe younger kids, it's less than optimal for a lot of folks. So we now have new modes of administration. We'll talk a little bit more detail about them. But again, different patients surprisingly have different preferences of what they like. Again, education and training is everything. I firmly believe no one should leave either the physician's office without being trained on how to use these different treatments, nor should they leave the pharmacy without the pharmacist once again going over how to use the drugs. Again, we know repetition works here. We know that within the different formulations, for example, and I said that patients have different preferences. Again, intramuscular formulations, the military uses this, for example. Lots of patients do not want to use needles. The intranasal, some patients just simply don't like it, and some patients will complain of some local nasal mucosa irritability, although they're generally well tolerated. But they also do require a little bit of administration technique. If any of you have ever used any kind of nasal spray before, you know that there's a certain things you should do, whether it's tilting your head or making sure things don't run out, or blowing your nose if it does cause some irritation. So for some patients, while it seems like it's a very convenient route, it may not be, and it may cause some side effects. And again, rectal application, amongst the many things that rectal applications can do, if administered inappropriately, can be uncomfortable and can cause some pain. Now, I've been talking about seizure action plans a lot this afternoon. And again, I'm thinking that with this audience, you're likely familiar with this. I just want to, think that they're now, these plans, we redid these plans back at the beginning of the COVID era, really with emphasis on when to call 911, or when to really call your provider first. We used to tell patients that patients were much more likely to go to the emergency room. We're really doing what we can now to educate people. Let's not jump to that yet. Call and talk to somebody. So we're also trying to work with some of the different hospital settings for the triage staff, triage nurses, to be able to talk through some of these general considerations. First aid for seizures. I think this is now something, again, through the Epilepsy Foundation. You may or may not be aware that we now have a Epilepsy Foundation seizure first aid training module. If you haven't been gone through seizure first aid training, I'm happy to do that for you. I'm happy to, I'm one of the instructors for the foundation. But it's important that we try to get this out to as many people as possible. People in different workplaces, school teachers, not just school nurses, a variety of folks. As more people we can get trained on seizure first aid and what to do and what to look for, the better our patients with epilepsy will be. But we also have sections on here, really very importantly, when will a rescue therapy be used? And what type of rescue therapy is the most important? Okay, so for every patient, as long as we can get the basic information, I'm really happy. But if we do opt for a rescue treatment, we really need to have that conversation about which is the most reasonable treatment approach and how do we want to use it. And again, for some patients, I may not use anything. I'm trying now for making an effort that all of my patients have one of these rescue plans, but the rescue plan may be just understanding first aid and when to call 911. It may not be necessarily providing them the drug. Okay, so no, I'm going back and forth a little bit. Let me talk a little bit about some more detail about the drugs. The major drugs that we use are the benzodiazepine medications. one of the things that we're concerned about, I showed you a diazepam study. One of the things we're concerned about that if I treat a patient, am I going to get long-lasting protection from having that recurrent seizure? And if you recall when I showed you the diazepam study, that I've got a pretty good likelihood that once I give a dose of diazepam, because it's long half-life, I'm going to get some longer protection. Now, we can debate whether or not between diazepam and midazolam. Again, both of these drugs have been FDA evaluated and shown to be effective. But again, I want something where I want to minimize the chance that I'm going to have to quickly redose my medicine. I'm going to have a prolonged effect. Okay, I talked about the intranasal formulation. Again, we now have 2 products that are available, Valtoco and Nasolam. I'm sure you now have clients that are using one or the other or asking you about them. My advice is for them to talk to their physician for physicians, pick one, get comfortable with it. Between the intranasals formulations, I think we don't have head-to-head studies, no pun intended, but they're both effective and they both work. But again, as I mentioned, some patients are not crazy about the idea of using an intranasal formulation for whatever reason. So we need to have other options that are available. And that's where, again, the newer technologies that are coming on, like the buccal film technology, again, that's a strip that we can put in the side of the mouth that rapidly dissolves and drives drug in through the cheek, is a really very good treatment option for some of our patients. Now, I've had people ask me, well, what's wrong with good old Diastat, the rectal gel? Well, besides the obvious, that it may be socially unacceptable, especially in an adult patient who's out in public. Most adults are not going to want somebody, if they're in the middle of a mall or some other public venue or at work, administering a rectal medication to them. And it may be very difficult to do that. It also may be very difficult to get a caregiver or somebody else to want to do this. It requires positioning of patients. It may or may not be easy to do, especially in a larger patient. So again, there's a variety of technical, sort of, if you will, and social problems with Diastat. I am grateful. I mean, what Diastat did do for us, however, the rectal diazepam gel, is that it really opened the door a number of years ago and proved that patients and caregivers could reliably treat these seizures that otherwise required going to the emergency room. Okay, I've talked a lot about the intranasal. These are fairly easy to give compounds and fairly easy to do. In most cases, it's been caregivers who's administered the drug, not necessarily the patient. And the patients may need to, again, continually carry a little nasal device with them. Sorry. So what's new then? Okay, I said if a patient wants to use intranasal, I think either option is good. Again, I'm encouraging clinicians, get familiar with one of them and know how to educate your patients. Use one of them. This buccal film technology, so that's the new thing. If patients they don't want to use an intranasal, I've already told you this strip. It has the advantages of an oral medicine without having to swallow anything and without having to take water. Simply, again, putting the strip on the side of your mouth, it rapidly dissolves. It drives the drug, if you will. It's called transmucosal absorption, drives that drug in through the side of the mouth. And it provides the same coverage, if you will, the same blood levels of diazepam that we would get from our gold standard Diastat but with much less variability, much more consistency. And one of the clinical trials that was done, one of the things that you may be asking yourself is, gee, I've always been told, don't put anything in my mouth or in somebody's mouth when they're having a seizure. And interesting enough, in one of the studies they looked at, did anybody get bitten by doing this? And the answer was no, because you're not putting it under the tongue. You're not putting it inside. You're pulling in the side of the cheek. Again, so very, very consistent. And it offers another alternative. So this is kind of, let me bring this home, and I now want to open this up for questions. So let me just bring this home. Seizure clustering, when you really start asking the question and interviewing patients, it happens a lot more than many of us think, at least many of us clinicians think. They can present differently. Patients will sometimes use different language. They may not understand if we say acute repetitive seizures. They'll say, well, no, they weren't repeating. So again, we need to make sure we're having good communications. We now have a variety of therapeutic delivery options, and this gives us an opportunity to really work with patients to individualize for them. I am adamant, I think that every single patient with epilepsy needs to have an action plan. They may not need a rescue medicine, but they need to have an action plan, and that needs to be refreshed, if you will, periodically to make sure that it's still relevant. We now have some really interesting FDA-approved compounds, and hopefully in the near future, we're going to have yet another couple to offer our patients. So with that, I want to thank you for your time and attention tonight, and I'd like to now open it up for questions.
Dr. Gidal, thank you again so much. I have not seen any questions come across here, which might just mean that we don't have any questions tonight. However, our audience certainly knows how to get in touch with us at Epilepsy Foundation New England, and we'd be more than happy to put them in touch with you to help answer those questions.
Okay.
So thank you so much, Dr. Gidal, and for Aquestive for putting this together. Really appreciate your time tonight, and I hope everyone has a great rest of their evening.
Okay, great. Thank you.
Thank you.